Welcome to our symposium on overcoming cancer-related anemia with intravenous iron. I'm George Rogers, a hematologist at the University of Utah. I'll introduce the rest of the panel in a moment, but first of all, let me go over some housekeeping items. So I'm not going to read the disclaimer. It's in your syllabus as well as on the website. This symposium is presented by CEC Oncology and supported through an independent educational grant from American Regent. So the learning objectives, I will just very briefly run over. We're going to go over the principles of iron metabolism and absorption. We're going to go over the pathophysiology of iron deficiency anemia. We're going to go over cancer-related anemia. We're going to go over the utility of certain laboratory tests, such as serum ferritin and transferrin saturation as diagnostic aids. We're going to go over a review of clinical trials of IV iron therapy for cancer-related anemia. We're going to go in detail about functional iron block and how it can be overcome with IV iron. And then we're going to go over several cases to illustrate the above information. And then lastly, we'll go over some economic analyses of using IV iron products. So again, I'm George Rogers. The rest of the panel, Dr. Michael Auerbach, Professor of Medicine at Georgetown. Tom Delary, Professor of Medicine at Oregon Health Sciences University in Portland. Patricia Ford, Professor of Medicine at the University of Pennsylvania. John Glaspie, Professor of Medicine at UCLA. Here are our disclosures. Again, this information is in your syllabus and on the website. So if you're interested in CME credit, you can scan the code listed on this slide. It's also again in your syllabus. There's an electronic version of the syllabus available at the website shown. And again, this is the QR code is also in your syllabus. Finally, CEC Oncology has prepared a resource tool available at this website that goes over algorithms that we will discuss in this symposium. These are available in PDF format if you wish to download them. We ask that if you're not eating to please wear your mask. And if you have a question for the faculty, please scan this code or go to this website. We will also have people circulating in the room with cards to write down questions. So either write them down or submit them electronically at this website. So let's go to our panel discussants. We'll lead off with Dr. Delary talking about foundational principles of iron metabolism and absorption.
Thank you very much for being here and being on video. Ironic, we were talking about Denali, and I start off with a picture of Denali National Park. So again, I'm Tom Delary, and let's begin with the basics. Let's go back to Iron Metabolism 101. And I think that will give us some insights and help set the stage for the rest of the excellent talks tonight. So iron absorption. Iron is typically, we ingest it in the ferric form. Stomach acid converts it to the ferrous form, and it's absorbed mainly in the duodenum and the proximal jejunum via a specific receptor DMT1. That's why many of my bypass patients, especially those with the old-fashioned duodenal switch or commonly Roux-en-Y, have such trouble with their iron. Now, in the enterocyte, iron can be stored and then sloughed away when the enterocyte sloughs away, or it can be transported through the cell membrane and exit into the circulation. And one of the key proteins you're going to hear me talk about tonight is ferroportin. And I always think of it as the port of iron. That's how iron is exported from any cell. And so that's how it gets into the circulation. And so again, a little bit more diagrammically, but we see here dietary iron is absorbed, it can be stored or exported by ferroportin. Another key player you're going to hear about a lot tonight plays a role in this too is Hep-Cyton. And Hep-Cyton has many interesting activities, which I'm going to keep everybody in suspense as we talk about. So iron is very key. It's interesting, we only absorb and lose a little bit per day, but it has many functions. So again, we absorb iron, it's transported through the blood by transferrin, And it can have many different types of fate. The key one is to be delivered to the developing red cell to make hemoglobin, which carries oxygen. And that's the primary area where iron gets targeted. If we have enough iron, then iron goes into storage, mainly in the liver. It can also be part of many key enzyme systems. We'll talk a few slides down. And then the body can recycle iron. So our bodies were recycling more long before it became fashionable. And in the spleen, when the red cell's broken down, the iron is recycled. And so if we think about iron, it has many fates in the body. It's absorbed in the duodenum and just transferred to the plasma. It's recycled in the spleen, the reticuloendothelial system, and goes to the plasma. Again, iron is delivered to the bone marrow for red cell production. And any extra is then put into storage in the liver, where it can be liberated to, again, make more red cells. Now, Hep-Cyton is interesting. In many ways, it's the master regulator of iron, because if you have Hep-Cyton, it actually blocks many steps of the iron cycle, as we'll go through. It blocks absorption. It will block release of iron from recycling in the reticuloendothelial system, and it blocks the release of iron from the liver. So Hep-Cyton turns out to be a very powerful negative regulator of iron. Now, how much iron do we have and where does it go? So again, as I emphasize, we don't absorb that much iron daily, maybe 1 milligram of 2 a day, a little bit more for really iron deficient. And this balances our losses, about 1 milligram a day for men, 2 milligrams a day for women, mainly due to obligate menstrual losses. But there's a considerable amount of iron in other tissues. Our red cells need 30 milligrams of iron a day. So about 2.5 grams of iron are in our erythrocytes. Our muscles have a lot of iron in it. We need it for myoglobin, the oxygen acceptor in the muscle, and there's about 300 milligrams. And that's why athletes are really honed into their iron status, because that actually gets depleted first. And a common thing I'll see in my athletic Oregonians is when they start to get iron deficient, complaining about their running times going down. Storage iron varies greatly. For good, abundant stores, it can be up to 1 gram. Again, many patients we see are iron deficient, but even many young women are also iron deficient and really have almost 0 iron stores. So it's really interesting that while only a little bit of iron is absorbed and lost, our body is very efficient at recycling and using the iron. Now, there's 2 key proteins of iron metabolism. Transferrin, which I call the U-Haul of iron, which picks up the iron from the liver, from the intestines, delivers it to where it needs to go. And then for long-term storage, there's a huge molecule called ferritin. So again, transferrin has 1 to 2 sites to bind iron. It's the transport of iron. And then ferritin's actually like this giant shell of 24 subunits that stores iron. And I always call ferritin the warehouse of iron. So you see here in this nice diagram, ferritin's an interesting molecule. It's actually like a giant sphere, and we can store up to 3,200 iron molecules in it. And 24 ferritin subunits make this up. And so these leak out and are actually the ferritin we measure. And as I tell my students, the ferritin is the bricks of the warehouse of iron. Now, sequestered iron is stored in the +3 form, and this is converted from the +2 by a ferroxidase activity in the ferritin shell. So most of our ferritin is where iron is stored, especially in the liver, the macrophages, a little bit in muscles and other areas. And if we don't have inflammation, the little bit of that leaks out is what we measure to determine iron stores. So again, iron stores, most of it's in our blood, up to 2/3 of it can be in hemoglobin. Again, other proteins, especially myoglobin, a lot of enzymes also play a key role for iron. Their storage, again, as I said, this varies tremendously. And it's interesting, the iron we measure in the blood and in the transferrin is actually a very tiny part, although as we'll see, crucial for some of our testing of our total body iron stores. And here's a nice diagram, again, that kind of ties together some of the themes I've been going. Again, we absorb iron about 1 milligram or 2 a day in the duodenum. We lose iron by by menstrual losses, by sloughing skin, sloughing intestines, about cells, about 1 to 2 milligrams a day. Iron is very active, transported to developing red cells where most of our iron is, and in the muscle. And then we have the ability to store extra iron. Now, how does iron get to developing red cell? Ideally by 2 ways. One, we deliver it from the gut where it's absorbed, delivered to the blood by ferroportin, goes to the transferrin, and then binds to the transferrin receptor. Secondly, we have stores. So if there is a deficiency in oral intake, then we can get iron from the ferritin stores and liver macrophages, and again, exit through ferroportin and then delivered to the bone marrow. Now, it gets into the red cell by an interesting mechanism. Transferrin binds something logically called the transferrin receptor. The transferrin receptor gets incorporated into pits and absorbed into the cell. This absorption, cytosol, where the transferrin is, becomes acidic, and the iron pops off and then gets delivered to the cytoplasm via DMT1. And then the body can actually recycle the transferrin receptor. And this is kind of key that's recycled. I read a little trivia fact that the developing red cell can bind 80,000 molecules of transferrin per second. I don't know if that's actually true or not, but it's one of those fun facts that I like saying. So again, here more diagrammatically, we can see the transferrin receptor. We can see the iron-loaded transferrin molecule binding to it. Again, we see the endosome. It actually becomes acidic. Ferritin pops off, gets shot out by DMT, where it can be used in the mitochondria to make the heme, or it can be stored. And again, the transferrin receptor and transferrin is recycled. So again, everything very efficiently used and recycled. Now, how does iron get out of a cell? And again, that's where ferroportin comes in. So again, as I like to call it, the port of iron. So no matter what happens to iron in the cell, in the macrophage, it's exported via ferroportin, where it's delivered to transferrin. In the hepatocyte, again, it's delivered out of storage to ferroportin, where it can be bound to transferrin. And again, as I emphasized earlier, in the enterocyte, in our gut, again, it's exported out. So physiologically, the only way iron can get out of a cell is to be shot out by ferroportin. So how can this go haywire? How does it go wrong? And that's what really leads to the anemia of inflammation. Now, if we think about cancer-related anemia, it's important to remember there can be other things besides inflammation can do it. Obviously, the underlying malignancy, maybe there's some hemolysis, somebody has lymphoma, autoimmune hemolytic anemia. Certainly the cancer therapies we give, myelosuppressive drugs, radiation. Again, all the crazy side effects we're now seeing with the checkpoint inhibitors can add to this. Certainly can be occult blood loss, or even not so occult blood loss, like a patient I'm currently dealing with who's having massive blood losses from a bladder tumor. Again, we can't forget the tried and true iron deficiency, really common in our GI cancer patients, folate and B12. And again, maybe there's other illnesses. They have kidney disease, they have heart failure. But again, a lot of the driver if these are okay, is inflammation. And that really brings up, how does inflammation lead to anemia? Well, what we think happens is several things. One, inflammatory cytokines can impair the proliferation and differentiation of red cell precursors. Again, these are especially with interferons, tumor necrosis factors. And it's interesting, when my patients get put on anti-TNF drugs, often their hematocrit goes up just from relieving the inflammation. We see a blunted erythropoietin response. If I were to phlebotomize myself every day, become iron deficient to a hematocrit of 20, my EPO levels would be in the thousands. If instead I set myself on fire, got anemia chronic disease, my EPO levels, even with a crit of 20, would go up to only the 10s or 20s. So we see a blunting of that response. But really what we discovered is an impaired iron response, impaired homeostasis. And that's where our friend Hep-Cyton comes back into play. Inflammation raises levels of hepcidin very dramatically. It's an acute phase reactant. So when it goes up, we can't absorb iron from the intestines, and we can't transport iron out of its storage, like the macrophages or the livers. So there's iron sequestration. We have the iron there, but it's literally locked up, unable to be used. So this complex slide but drives home several points. One, inflammation. Again, cancer, infection, inflammatory diseases leads to a slew of cytokines being released. They have a lot of effects on the marrow, but one of the big effects they also have is it generates hepcidin. Hepcidin binds to ferroportin no matter where it is, in the enterocyte, in the hepatocyte, in the macrophages. It leads to downregulation of ferroportin. No ferroportin, you can't export iron, and your iron is sequestered. And that seems to play a very key role in the anemia of inflammation, is this sequestration of iron. And this has an impact. As you know, part of it's just common sense. If your patients are anemic, they're going to be tireder. But we notice that when we look at breast cancer and we look at studies of quality of life, the more anemic a patient is, or if they have anemia, the worse their quality of life is. And even with hemoglobin levels that may not be that abnormal. So again, this anemia of inflammation is more in a lab finding. It's something that we see in clinic and affects the quality of life of our patients. So again, inflammation reduces iron availability, and this is via hepcidin. Inflammation makes hepcidin goes up. In the enterocyte, you block ferroportin. No ferroportin, you don't absorb iron. In the macrophage, ferroportin's blocked. In the hepatocyte, ferroportin's blocked. You don't release iron from iron stores. Again, it's sequestered. What this leads to at the level of the red cell, it's an iron deficiency. So that's why a lot of times anemia of inflammation can be a little microcytic. We see hyperchromia because at the level of the developing red cell, it's not getting iron. And so it's a form of iron deficiency. Now, the other interesting thing we have discovered is what else makes hepcidin go up? Iron. And again, it's a feedback mechanism. So if I took a Fred Flintstone vitamin this morning with a lot of iron, maybe Barney Rubble, then what would happen is that as soon as it's absorbed, my levels of hepcidin rises. And was shown as this very elegant study from a few years ago, just any amount of iron will then lead to a rise of hepcidin. And this rise in hepcidin lasts 24 up to 48 hours. So that's why when I give iron, I give it once a day at most, because if you give a dose at noon, in the evening, if somebody's had their morning iron, it's not getting absorbed. It's just going to stay in their gut and give them lockbow. And so this has been a key finding that even normal physiology of hepcidin really limits how far we can go with oral iron, because once somebody takes an oral iron, hepcidin goes up, and we really don't get that much absorption the rest of the day and even going into the next day. And we also can see physiologically what happens. This was a study that synthetic hepcidin was given. We looked at iron levels in mice, and we noticed that immediately, within 30 minutes of getting hepcidin, iron levels, serum iron levels plummeted. That's because iron could not be released from stores, couldn't be absorbed, and this stayed up for at least 48 hours. So we're realizing now hepcidin is a very key player, really leads to sequestration of serum iron. So what are the clinical implications of hepcidin? Well, think about it. If you have a lot of hepcidin, you have decreased intestinal absorption and increased sequestration. This is why analogs of these drugs are like being studied in iron overload states. But if you think about if you have too much hepcidin, you're going to get decreased serum iron, decreased iron deficiency, iron delivery to the red cell, and clinically, it's going to be an iron deficiency and iron deficiency anemia. And what do we see in the marrow? Well, this is some normal marrow studies. We see the nice Prussian blue stain, the dark blue showing iron, and we see the little iron spots, the sideroblast, showing iron is being delivered to the red cell. We see an iron deficiency, obviously no iron. But the other picture shows functional anemia. We see good iron stores, but we don't see those little particles of iron being delivered. I remember when I was a fellow in training, we'd always do bone marrows on small cell cancer patients for staging. We never saw small cell, but we always saw in the iron stain functional iron deficiency. We'd see tons of storage iron. We'd see none of these sideroblasts. So this leads to a key thing that is really kind of the new lingo we've just, when we talk about iron the past few years, absolute versus functional iron deficiency. And what the heck is that? Absolute iron deficiency is when you have low to no iron stores. So the idea is that by reduced absorption, increased losses, whatever, you're truly iron deficient. You have low iron stores. So there's less supplies to be delivered to transferrin, less supplies for transferrin to deliver to the developing red cell. You become anemic. Now, that's the iron deficiency we've all been familiar with. What was really been identified in many different areas of medicine is functional iron deficiency. We have great stores of iron. They may be even very high stores of iron, but they aren't getting delivered. So due to raised levels of Hep-Cyton, we not only block absorption, but we block this release of iron. So again, where we need iron, especially the developing bone marrow, we're not getting the iron delivered. So it's really, again, an iron deficiency, but it's more a functional one. The iron is there, but just simply cannot be delivered. And we see this over and over. We certainly see in cancer patients. There's been a revolution in heart failure, which realized this has been a major mechanism. And now, especially with the European guidelines, giving iron as a major recommendation. We see it in our renal disease patients who need a lot of iron for their EPO and other erythroid stimulating drugs to work. And this is just because we got to get the iron delivered. And in functional iron deficiency, it's not being delivered. And again, show it diagrammatically, we have normal, and then become iron depleted as our iron stores fall. And again, this is the classic thing we think of an iron deficiency. We have depletion of stores, and then absolute iron deficiency, where we get anemic, we get microcytic. But we have to add to this now our diagram, functional iron deficiency, where we have great stores, but they're not going anywhere. The highway has been barricaded, that it's not getting delivered. And again, where the iron is needed the most, to the bone marrow, to developing red cells, it's simply not being delivered. And this is a nice diagram to kind of show how we think about this. Certainly the ferritin is low, and different people have different cutoffs, but the ferritin's very low. We have absolute iron deficiency. Again, we have no stores, we're iron deficient. But what we're realizing now is that even if the ferritin's higher, but the saturation is low, that is a marker of functional iron deficiency. Because what is the iron saturation? It is, the key part of the number is the serum iron divided by the TIBC. If you have little serum iron, your saturation is still going to be low. So this is very suggestive of functional iron deficiency. And that's why I like to use the saturation to screen for. Obviously, if somebody has a high ferritin, a high saturation, you need to think about other issues. But this is why the TSAT has really become a nice differentiator for us worrying about functional iron deficiency. And we see this, as I talked about, in a lot of different situations. We just talked about cancer and chemotherapy. Heart failure is an inflammatory state. Patients with heart failure have high levels of TNF, high levels of inflammatory cytokines, and they have high levels of Hep-Cyton and functional iron deficiency. Chronic kidney disease, we see it. Inflammatory bowel disease is a nightmare for iron metabolism. Not only do you have ongoing iron losses from lack of absorption, ongoing bleeding, but you have this very intense inflammatory milieu that is also leading to a functional iron deficiency. And certainly our patients with severe autoimmune disease like RA or lupus, a lot of their anemia is driven by this functional iron deficiency. So again, it's really a unifying theme of the anemia and inflammation are these high levels of Hep-Cyton leading to functional iron deficiency. So what would I like to summarize and say? Well, I think we've covered a lot of things, but we can summarize in a few words. One, that iron metabolism is really key on ferritin and transferrin. So we are nice that we have labs and the ability to measure these due to serum ferritin and the saturation. And that really helps us figure out the labs and everything. Secondly, absolute and functional iron deficiency are unique and can be distinct. Again, different people, as you'll see in this talk, have different cutoffs for ferritin for absolute iron deficiency. But again, a low ferritin, low saturation, absolute iron deficiency. Call the gastroenterologist for a GI workup or talk to the OBs about the heavy periods. Functional iron deficiency, we have great iron stores, almost always a ferritin over 100. But again, we see the low saturation. The iron is there, but it's not being delivered. And why is this? As we see in so many diseases I talked about, Hep-Cyton is central to the development of functional iron deficiency. No matter what's driving your inflammation, you're anemic because you have high levels of Hep-Cyton, and this is blocking iron from being delivered to the red cell. Now, as we'll talk about, because your gut's not going to absorb iron, oral iron's not going to work, and we need to really think about intravenous iron. And we have to remember that cancer-related anemia is a big deal. It's a linear, statistical significant impact on the patient's quality of life, and that's why it's important to recognize these anemias and know the role of iron in functional iron deficiency. And I'll pass the baton to Dr. Auerbach, I think is next. What?
And if you have questions, you can either submit them electronically at the website that's in your syllabus, or there should be people circulating with cards to write down your questions. So our next speaker is going to be Dr. Michael Auerbach from Georgetown. Just to tweak your interest in his talk, he's going to show us a fascinating video of a patient having a minor infusion reaction in real time. Michael.
Beautiful job, Dr. Good evening. I hope when I'm done, I'll leave you with a new thought process on how to begin therapy for patients with iron deficiency, move away from an ancient guideline to give oral iron first. Just to give you an idea, I mean, clearly this is not the sexy topic that multiple myeloma and other hematologic malignancies are. However, in terms of prevalence, it's 100 times more common than all cancer combined. There are about 3 billion cases worldwide, but we use a term called years living with disability. It's a statistical measure of morbidity of an illness. And iron deficiency is #1 across 35 countries. It's in the top 5 of virtually every country in the world, including the United States. And it is the leading cause of years lived with disability in low and middle income countries. Now, this is a marvelous piece that was just published in JAMA Network. And what it really shows that if you take a look at hemoglobin cutoff levels, define anemia in healthy individuals, we are way on the low side for most non-pregnant women. How it happened is beyond me, but for some reason or other, women are considered normal if they have mild anemia. And further, you know how many deficits there are over the years in women's health. And I think there's really plenty of reason for us to start moving forward with a more aggressive paradigm to replete iron. This paper was just recently published in Lancet Hematology, and it takes a look at ferritin thresholds. If you take a look at LabCorp or Quest, they'll tell you that the lower limit for ferritin is 15, and for percent saturation, 12. Well, that borders on ridiculous, because a ferritin of 30 has a 98% sensitivity and a 92% specificity for absent marrow hemosiderin, a point at which there are simply no iron stores to handle anything that might come up. And this paper by May et al. Certainly supports that position. Iron deficiency is the disease. Anemia is an effect. We have almost no guidelines anywhere for the management of iron deficiency without anemia, and yet there's now a litany of new papers of the benefit of not only treating non-anemic iron deficiency, but the superiority of intravenous iron over oral iron in improving energy, activity, and quality of life. And I will point out as we go through this why intravenous iron will overcome so many of the situations in which oral iron is either harmful or ineffective. We don't ask our patients how long they have symptoms. Most doctors don't ask whether there's pagophagia, a craving for ice, restless leg syndrome, a miserable disorder keeping people awake. And the attention to these symptoms, which lead to so much morbidity worldwide, is truly inadequate. These are marvelous slides from Toby Richards, a professor at Western Australia, who is now looking to create an entirely new paradigm to the approach of what just so happens to be the commonest malady on the planet. Iron deficiency anemia in cancer and chemotherapy-related anemia has multiple etiologies. As Tom explained, the role of inflammation is formidable. It occurs in more than 30% of patients and often prior to the initiation of chemotherapy, which worsens anemia because of its effect on bone marrow production. It influences survival and is ubiquitously associated with poorer outcomes. It's characterized by an inflammatory anemia or absolute iron deficiency, and the chemotherapeutic effect itself has a direct anemia etiology with approximately a 70% prevalence among cancer patients. I showed you this slide because I want you to think of what a potential new paradigm is. There are two autoanalyzers which have the reticulocyte hemoglobin content on it. You all know how excellent the transferrin saturation is on informing for a need for iron, but the TSAT and the serum ferritin still take a day or two to come back when the blood is drawn in your office. But wouldn't it be nice if in 40 seconds after the patient arrives, you get a piece of information that tells you whether or not you need to administer iron? And so I'm not taking away from the importance of finding out whether it's absolute or functional iron deficiency. But the CHR now has shown to have a very high concordance with the need for iron or the lack of need for iron. And this is a paper we just published in Mayo Clinic Proceedings. Carlo Brugnera from Harvard was really the impetus behind this. And this took the reticulocyte hemoglobin in consecutive patients coming in, and a high reticulocyte hemoglobin above 28.5 clearly supports the lack of need for iron, and a low one does just the opposite. Iron deficiency, most symptoms of iron deficiency are vague, but the ones that are specific we often don't ask for. Pale, fatigue. As physicians, how many patients tell you they are tired, headache, symptoms that are difficult for us to put a hand around? Frequent symptoms like hair loss, depapillation of the tongue. Remarkable how often we don't examine the tongue to look for the presence or absence of papillae. Restless leg syndrome, which occurs in upwards of 50% of iron deficiency, makes the exhaustion worse because of lack of sleep. And then you have a host of non-specific symptoms until you come down to the bottom. Pica, but most frequently, pagophagia, a weird pathological craving for ice that is clearly related to iron deficiency, as I have seen in thousands of patients where the symptom literally goes away during the middle of the infusion. I hope before I'm dead, I understand that mechanism, because it's certainly not hematologic with improvement in minutes. Less common are spoon-shaped nails, but if you take a magnifying glass or just pick up the fingernails and look at them closely, you can see the remnants or the early portions of these spoon-shaped nails called koilonychia, which almost date the iron deficiency like rings around a tree. Sydenham first used iron in the 1500s to treat what was then the green sickness, because severely iron deficient patients did look green. It was first described by Lang in the 1500s, and then Sydenham used iron filings in cold wine to treat the green sickness in 1687. So I misspoke at the beginning of this bullet. Then Blaud renamed it chlorosis, and he was the first to use ferrous sulfate. And by the time the American Civil War came along, iron was already being used to treat war wounds. Today, it's the most common micronutrient deficiency on the planet, with an estimated greater than 35% of the world's population and more than 50% of gravidas worldwide. This has an enormous implication because intranatal iron deficiency has now been shown in high-quality neonatology studies to be associated with a statistically significant increment in autism spectrum disorders. It's 100 times more prevalent than all cancer combined. And here we are, almost 600 years later, using the often ineffective and usually poorly tolerated oral iron as our frontline therapy. And these side effects are extremely common: constipation, less often diarrhea, metallic taste, nausea, cramping, a side effect we don't ask about, difficulty cleaning after evacuation with thick, green, tenacious stool. IV iron does cause reactions. They're up to 1 to 3% of the time. But you all learned when you went to school that IV iron is dangerous because of anaphylaxis. The truth is that it occurs in less than 1.25 million infusions. And I'm not going to talk about anaphylaxis, because if you're going to give intravenous anything, you need to be prepared to deal with acute hypersensitivity. It's enormously more common with chemotherapy than it is with iron. But the minor reaction of pressure in the chest or the back, or headache, or facial flushing, which I'm going to show you, occurs about 1 to 3% of the time, and it's the inappropriate intervention with vasopressors and antihistamines, both of which should be avoided, taking this harmless reaction and turning it to a hemodynamically significant serious adverse event that fuels the folklore of danger. You've got a bunch of oral irons. I'm not going to read all of them. There's one that's left off. Lactoferrin is gaining some traction now. It seems to have equal efficacy with a little bit less toxicity. But to date, not a single iron formulation has been shown to be both less safe and more effective than ferrous sulfate. It works in uncomplicated iron deficiency, and if taken and tolerated and effective, those of you who take care of anemic patients, you know that's a rare trifecta, is cheap and readily available. But more than 70% report significant gastrointestinal perturbation. Here is a study by Tolkien et al., published in PLOS I in 2015, which looked at prospective studies comparing oral iron to placebo or intravenous iron and actually showed that more than 70% of individuals reported significant gastrointestinal perturbation. The OBGYN literature is rife with publications reporting unacceptably high incidence of side effects in women prescribed oral iron. But there is some hope. As Tom elegantly showed you with the role of Hep-Cyton in iron metabolism, high-quality papers from Michael Zimmerman's lab in Switzerland. The first one, Moretti et al. In Blood, and the second, Stoffel et al. In Lancet Hematology, and most recently, Uyaji et al. In the American Journal of Clinical Nutrition, show that when you swallow iron, Hep-Cyton goes up. And if you take iron once a day, or twice a day, or 3 times a day, as you can clearly see, the amount of Hep-Cyton goes up and the amount of iron absorption and fractional iron absorption does not. Here you have alternate day dosing for 28 days or consecutive day dosing for 14 days. There's a 30% increment in absorption in the alternate day paradigm. But let's say there was no difference in absorption. What you are also not seeing on this slide was a 35 to 40% decrement in side effects. So this would be a slam dunk if it wasn't better, and I believe it is a new standard, and we are already recommending it as a reasonable alternative for frontline oral iron therapy in our section on the treatment of iron deficiency in adults and up to date. Here you actually have the data, alternate day dosing versus consecutive day dosing. It's highly statistically significant with 2 zeros and a 1, showing how improved the absorption is with the considerably less toxic alternate day regimen. And here's a wonderful graph that Michael sent me. And as you can see, the Hep-Cyton goes up at around 24 hours. It comes down at around 48 hours, which works perfectly with the recommendation to take iron every other day to get past the Hep-Cyton block on absorption. These are the available formulations in the United States and most of the Western world. I guess this is in 2 slides because we're missing a few. Low molecular weight iron dextran is approved as a 100 milligram bolus, but nobody gives it that way because it's ridiculous. It requires 10 doses to do what you can safely do in an hour with 1,000 milligrams. Ferumoxytol is approved as 510 milligrams twice, but can also safely be given as 1,020 milligrams once. And 5 papers have been published with that paradigm. Ferric gluconate and iron sucrose require 4 to 7 doses to achieve what any of the other 4, 2 of which I haven't told you about yet, iron sucrose and ferric gluconate, both require 4 to 7 doses to give a total dose because they have much less tightly bound iron in their smaller carbohydrate core. Ferric carboxymaltose has a complex carbohydrate core with nanoparticle technology that allows a very large dose of 1,000 milligrams to be given in 15 to 20 minutes. However, ferric carboxymaltose in the United States comes only as a 750 milligram vial. I think that's going to change. They're going to have they've been licensed by FDA to give a gram, so it's just a matter of changing the vial size. And ferric dirisommaltose, the most recent to be reported, also can be given as 1,000 milligrams in 15 to 20 minutes. So you have 4 formulations: iron dextran, ferric carboxymaltose, ferric dirisommaltose, and ferumoxytol, thank you, that can be given as a single infusion. And for that reason, I think we should not use iron sucrose or ferric gluconate for outpatients because it has no advantage in safety or efficacy and is markedly less convenient. And this is a paraphrase of a diagram in our paper that shows you the nanoparticle technology. So what happens is you have a sophisticated carbohydrate core that binds the iron tightly, releasing it slowly. And this is a an example of low molecular weight iron dextran, but with ferromoxetol, ferrocarboxymaltose, and iron isomaltoside, you have very similar physiology. All of these release iron quite slowly into the circulation, allowing a large dose in a short period of time. So to take this a little bit more clinically from what Tom told you, when you give intravenous iron, unlike oral iron, it immediately gets into the circulation, saturates transferrin, which then brings iron via the receptor to the erythroblasts. The circulating macrophages pick up the intravenous iron. They can't pick up the oral iron because it's not absorbed. Now, this I did not know until Clara Chemaskela told me this elegant physiology, that when the macrophages load with iron, upregulation of two regulatory proteins, iron regulatory proteins 1 and 2, occur, and subsequently by upregulating ferroportin, overcoming the Hep-Cyton block that you heard about so clearly in the previous talk. And the benefit that we see with ESA reductions and the decreased time to targets in chronic kidney disease and cancer-related anemia certainly supports this hypothesis. The next generation of intravenous iron has to overcome the stigma of danger with statistics. And I think what you can see on this slide, which is absolutely incorrect on the right, systematic reviews in millions of doses, tens of millions of doses, now support very clearly that SAEs with the administration of intravenous iron, if you don't screw up the minor infusion reaction with epinephrine and diphenhydramine, occur in approximately 1 in 200 to 1 in 250,000 administrations. Here's a paper, a review by Avni et al. That compared intravenous iron to placebo, no iron, oral iron, or IM iron. The latter should never be given to anyone at any time. It's cruel, it's painful, it has no advantage. And there was no increase in serious adverse events compared to any comparator, including placebo. All IV medications have the potential to cause serious hypersensitivity reactions, but these reactions are extremely rare, even more so with the newer intravenous iron products. And gross misrepresentations surrounding the management of these minor reactions, which were really described by Steve Fishbane first, and curiously published by me in Lancet for the first time in 2007, are minor, self-limited, and likely complement-mediated and go away without therapy. Now, I would like to start this video, which was done because I'm doing a study with my colleagues in India. Can you start it, please? Okay. This is my infusion center. You see one of our nurses administering intravenous iron. This young woman had no risk factors for an allergic reaction. She was not pre-medicated with methylprednisolone or with famotidine, and there was no reason to expect that anything would happen, but they do occur 1% of the time. Here you have a nurse who will be starting the infusion slowly. The reason we did this, because I couldn't go to India to teach the doctors how to give intravenous iron, and the nurses and the ASHAs for this study that we are doing on pregnant women comparing oral to IV iron. So this was a professionally made video. This was not orchestrated. This is not choreographed. All of a sudden, while we were filming the way we give intravenous iron, I get a call from the nurse. We're going to take a few seconds, watch what happens here. She's perfectly comfortable. There's her mother on the right side of the screen and our nurse standing there, obviously during COVID. And all of a sudden, this young lady feels pressure in the chest. Look at the anxiety in her eyes. Look at the color of her face. The nurses stop the infusion, which is what they should do, hang saline. This time, we treat the infusion reaction with methylprednisolone and famotidine, an H2 blocker. We do not give antihistamines because these are tryptase negative. Can you stop it for a second? Imagine if this young girl, epinephrine and diphenhydramine, with hypotension, tachycardia, diaphoresis, somnolence, and shock. Doesn't occur every time, but it certainly can. And then the next thing you know, you have a serious adverse event, ostensibly due to the iron, and the folklore is continued. Okay, we can restart now. So there really isn't much else to see, except that within 5 minutes of not getting excited and giving methylprednisolone and giving a steroid, which we did empirically because of its ability to block the arthralgias and myalgias that occur in about 10% of all patients receiving iron the next day. We don't have solid data that's randomized to show that it blocks this. But here we are 3-4 minutes later. Her face is gone. She was on her, her discoloration of her face is gone, and now she's smiling, looking at her cell phone. We can stop the video now and get back to the slides. The most important point here is, this young lady got the total dose of the drug that caused that reaction instead of being sent to the ICU or sent home and told she cannot get IV iron anymore. So what did I tell you today? I didn't say it, but oral iron is still considered frontline for those who can tolerate it, take it, and respond. For those disorders such as inflammatory bowel disease where it makes it worse, gastric bypass where it can't be absorbed because the iron cannot be conjugated to vitamin C, amino acids, and sugars in the stomach to protect it from being converted to ferric hydroxide in the proximal duodenum from the alkaline secretions of the pancreas, in abnormal uterine bleeding where it can't keep up with the losses, in the second and third trimester of pregnancy. Heresy. Oral iron should be contraindicated in iron-deficient mothers. It doesn't get to the baby, and the baby needs it for normal development. Published evidence suggests alternate day dosing is preferable. I think it's going to be our new standard. Oral iron has limited efficacy and tolerability in many. IV iron is substantially more effective than oral iron for iron deficiency of inflammation, chronic disease due to its capacity to overcome functional iron block by Hep-Cyton, the iron regulatory protein. The newer IV formulations are available as total dose infusions, obviating multiple visits, decreasing infusion reactions, and improving adherence. Frankly, adherence is 100%. Once you get IV iron, you can't give it back. IV iron is highly efficacious and much safer than not only most clinicians believe, but most clinicians were taught, and it should therefore be moved up in the cancer-related anemia, chemotherapy-induced anemia treatment paradigm, along with the paradigm for all of the disorders that are associated with increased inflammation or serious iron toxicity. Thank you very much.
Thank you, Michael. So our next speaker is going to be Dr. Patricia Ann Ford from the University of Pennsylvania. She's going to give us an overview of some of the clinical trials of IV iron in CRA.
Thank you very much. That is probably my favorite video of all time and should be a TikTok. So what I'd like to do really is give a little background. Again, I know you've heard some of this, but I'm going to be going through the clinical trials in cancer-related anemia and chemotherapy-induced anemia. And as we've been talking about, the anemia, chronic disease or inflammation, is the second most prevalent anemia and is certainly very common in cancers. In all of our cancer patients, about 30 to 40% of them come in anemic or develop anemia at some point. And the majority of our patients on chemotherapy, and that even includes with the advent of the new targeted treatments in immunotherapy. 90% of our patients with myelodysplastic syndrome certainly will also have some component of anemia. So the current treatment with ESAs has limited response and notable risk. So as we know, somewhere around 1/3 of our patients that get ESAs alone will not have a good hematologic response, and we are all certainly aware of the notable risks associated with the ESAs. So the CRAs and the CIAs lead to diminished patient quality of life, heightened transfusion requirements, and risks. Pushing my little green there, here we go. So what are the importance of adequate iron stores? Bioavailable iron is needed to maximize hemoglobin response to our ESAs, decrease transfusion burden, may lead to reduced hospitalizations and improvement of iron deficient symptoms and enhanced quality of life. And one of the things that I think, as Michael was also alluding to, is we look at iron deficiency in other patient populations. I do see a lot of women with absolute iron deficiency and pregnancy associated anemia, and I'm very aware now of the importance of just iron deficiency. I used to think that the clinical consequences would only be seen when I eventually had iron deficiency anemia. And now I really do understand that that's the end of the iron deficiency. And you can be very symptomatic with iron deficiency alone. And as we treat these women, they do have better cognitive function, more exercise, more stamina, and lots of their symptoms that we've already reviewed have gone away. It's also important as we treat anemia that we recognize the fact to keep up dose intensity, we may have to delay or reduce our cancer treatments if we have significant anemia or give transfusion support. So iron status, what to monitor and when. The key iron studies is certainly serum ferritin and our transferrin saturation that you've heard. Key monitoring time points is baseline, if you're going to be starting an ESA, failure to respond to your ESA within 8 weeks of initiation, and also if you have a complete or loss of initial response to your erythropoietic stimulating agents. So what are the specific benefits of IV iron? I hope as we go through these clinical trials, I'm going to be able to highlight to you that this IV iron does provide rapid and effective iron repletion. And as we mentioned with next generation products, often in a single dose, that it is very safe, highly tolerable. It's going to overcome the functional iron deficiency that's characteristic of cancer inflammation. And we're going to do this by overcoming our functional iron deficiency while avoiding the GI toxicity to our oral iron and noncompliance. So let's go through some of the clinical trial. I'm going to start out with highlighting a few of the randomized clinical trials, of which there's multiple, and then I'll eventually go into the meta-analysis. Multiple randomized trials in patients with CIA have been conducted comparing IV iron, and usually the standard treatment is oral iron or no iron. And these studies have shown that when we use parenteral iron supplementation, patients have a more robust, better hemoglobin response to ESA and decreases the percentage of patients that require transfusion. And this benefit has been seen in both our iron deficient and our iron replete patients. This just highlights some of the clinical trials that looked at adding parenteral iron to ESAs in chemotherapy-induced anemia. And as you can see, a lot of these papers we have here, the primary authors on our panel discussion, including my partner, Dr. Henry, who has taught me everything I know about ESAs and IV iron and has allowed me to treat. I have a specific patient population that I treat about 1,200 Jehovah's Witnesses a year for all different reasons, including cancer, don't have the ability to give blood transfusion, frequently can't give the ESAs because of a minute amount of albumin that some of them will not accept. So really had to look at these alternatives very intently and become very proficient at giving ESAs and IV iron. Here's a few of the clinical trials looking at IV iron as monotherapy. So knowing that the restrictions we have with the ESAs are pretty robust. As you know, we're only allowed to give the ESAs in non-curative intent, hemoglobin's under 10, except for myelodysplastic syndrome. So there are a very limited number of patients we can actually treat for anemia. So how about giving IV iron as monotherapy? And as you can see here, there's a number of studies that have looked at that with an improvement in hemoglobin and a decrease in some of these in red cell transfusions. So I do use a lot of intravenous iron as signal agent in my patients or before starting ESAs. So let's look at some of the randomized trials. So the first one, intravenous iron, optimizing the response to recombinant human erythropoietin in cancer patients with chemotherapy-related anemia, a multi-center, open-labeled, randomized trial by Dr. Auerbach. This looked at one of the first studies, look at randomizing 157 patients with chemotherapy-related anemia, hemoglobin's under 10.5, serum ferritin's under 450, or under 675 with a low TSAT. They all received subcutaneous erythropoietin at 40,000 units, and there were no adjustments to that dose that was allowed. The four arms were no iron, and the other standard oral iron at 325 ferrous sulfate twice daily. Again, an older study. We would now probably be giving that every other day, or not at all, the parental. Iron dextran repeated in 100 milligram IV boluses until the calculated iron dose was achieved. Again, older study. Iron dextran total dose infusion, and looking at the response of hemoglobin, so efficacy, and also looking at the different types of iron and quality of life, all measured at baseline and evaluated throughout the trial. So this one first plot looks at hemoglobin response, and although you can see we do have baseline, maximal, and hemoglobin change in all arms, I think the thing that I wanted to really highlight here was the increased magnitude of response that was seen in both the parental IV arms. Over to the right. Quality of life, you can see the vast improvement in energy, activity, overall quality of life in the two parental arms, some improvement in energy and activity in the oral iron, and actually diminished in all three in the no iron arm. So the trial conclusions was that there was a mean hemoglobin increase for both the parental iron groups, significantly higher than the no iron and oral iron groups with a good p-value. The percentage of patients with a hematopoietic response was significantly higher in the IV iron group at 68% versus the no iron 25, and oops, I forgot my 36% in the oral iron group with a good p-value. There was a significant correlation between an increase in hemoglobin and improvements in energy when the final data was pooled. Next study I want to go through, and again, I'm just picking a few of these, was another large study, a randomized multi-center controlled trial comparing efficacy and safety of darbepoetin, in this case, administered every 3 weeks, and that is when with or without the IV iron was also given. And in this study, there were dose adjustments to the ESA that was allowed. 396 patients with non-myeloid malignancies, hemoglobin is less than 11. You see a high darbepoetin dose of 500 micrograms, with or without IV iron, once every 3 weeks for a total of 16 weeks. And again, if we look at our hemoglobin response, our standard practice being the oral versus no iron versus the IV iron, we can see a 13% difference in our patients who achieved a hematopoietic response. And that was defined as a 2-gram increase or a hemoglobin of 12 without transfusion support. And to the right, we're looking at even the group of patients who achieved a hemoglobin over 11, and we can see the difference there of about 8% in our IV iron group. Looked at the reduction in transfusions, and we can see the percentage of patients here receiving transfusion support, which was highlighted in this paper, was certainly less in our parental iron groups in both of these. So this trial conclusion was the addition of IV iron to darbepoetin every 3 weeks in patients with chemotherapy-induced anemia was well tolerated. There was no significant adverse events in any of those arms. And the IV iron, like our first study, improved hematopoietic response rates, increased our hemoglobin level, and lowered the incidence of transfusions compared with the ESA alone. Some trials, however, did not demonstrate superiority for IV iron, and I'm going to highlight the Steensman one that is the top one in a minute. Right here, looking at when they first reported out IV iron, or oral placebo, and they demonstrated that there was no change in hemoglobin over time. And then also on the right, you can see there was an improvement in the measured ferritin as they went throughout this. There have been multiple editors that have commented on this and multiple meta-analysis that have commented on this study, saying that there may have been, as this is one of the only negative studies, potential contributing factors that have led to the negative results. One is there may have been suboptimal iron parameters in the enrolled patients, meaning low TSATs. So maybe some of these patients actually had absolute iron deficiency. There was a significant high dropout rate before week 16, and that was 1/3 of the patients in the arms. And one thought here is, although they gave a total lower dose of IV iron, and that may have led also to the negative results, their single dose of their iron preparation was about 50% what we would normally give. So the one thought is that that single dose at a much higher level led to adverse events or reactions and the drop-off of patients from the study. I'm going to switch now a little bit and cover some of the meta-analysis, which were all positive. Here's 3 of them that I'm going to review. Starting first with Petrelli with the addition of iron to ESAs in cancer patients, one of the first meta-analysis of the randomized trials that looked at 8 trials in anemic cancer patients. The trials arms that were included were ESAs that had parental iron, oral iron, or no iron. And again, our key endpoints here were hematopoietic response, as well as the time to respond. So as you well know, with our ESAs, not only are there about 1/3 of our patients who don't have any significant response, but it also is very long before we get a response, upwards to 4 to 6 weeks. Looked at the percentage of transfusions and again looked at toxicity. Over 1,600 patients from these 8 clinical trials were available for evaluation of this meta-analysis, and the relative risk of obtaining hematopoietic response, defined again as that 2-gram increase or hemoglobin of 12 without transfusion support, was 1.29 with IV iron and 1.04 for oral iron, along with a reduction in the risk of transfusion with parental iron over the no or oral iron. And the time to reach a response was 1 month shorter with the IV iron. Of note, no increased toxicity associated with any of the iron supplementations. This just looks at the forest plot here of favoring the parental iron, both for hematopoietic response and transfusion reduction. So their trial conclusions in this meta-analysis was the benefits of IV iron reduced the risk of transfusions by 23% versus ESAs alone, increased the chance of having a hematopoietic response by 29% versus ESAs. Oral iron did not increase hematopoietic response or cause any change in transfusion rates over ESA alone. So again, highlighting our improvement in ESA response, our reduction in transfusion burden, and I didn't show any of the graphs there, but also they demonstrated quality of life was improved and healthcare costs might be mitigated. Second meta-analysis out of the 3 I want to review, intravenous iron supplementation for the treatment of chemotherapy-induced anemia, systematic review, and meta-analysis of randomized trial. And this one looked at 11 trials between 2004 and 2011, having again about 1,600 patients, IV versus oral versus no iron. And the aggregate data here demonstrated the benefit of IV iron in chemotherapy-induced anemia. Again, look at the similarity here in the increased hematopoietic response rate in these trials with an RR of 1.28. Remember, our first analysis was 1.29. And again, decreased transfusion requirements and no significant increased risk of adverse events. This looks at the forest plot here. Again, this one favoring IV iron again for reduction in transfusion support. And also in another part of their subgroup analysis, they also found that hematopoietic response rates were found to directly correlate with total IV iron dose, suggesting the more iron, the better the response. So systematic review and meta-analysis of 8 randomized controlled trials is my last, comparing ESA and iron versus ESA alone. Total enrollment here over 2,000 patients. Hematopoietic response was again improved with iron and ESA versus ESA alone, RR 1.17. Subgroup analysis found this benefit was unique to IV iron in this meta-analysis and not any response to oral iron, which 3 of our initial randomized study did show some benefit and looked at oral iron. Iron supplementation also, again, caused a significant reduction in red cell transfusion requirements. So our top line conclusion is the addition of iron to ESAs offers superior hematopoietic response, reducing risk of red cell transfusion, improves our hemoglobin levels, and appears to be well tolerated. Same thing I said in all of the studies so far. Forest plot here, favoring our ESA and IV iron. So I'm going to turn our attention now to some of the guidelines we have for CRA and CIA management. recognizing there's still inconsistency, there's still not good guidelines, and we still have a lot of work to do. And highlighting again, remember the small number of patients that you're actually going to be placing on ESAs that have cancer and chemotherapy-induced anemia. So I'll highlight the ASCO-ASH, the NCCN, and the ESMO. So let's do NCCN, which again, a lot of these were just updated and took into consideration a lot of the clinical trials that I just reviewed to do some of their updates. So at least for the NCCN, you can see that they do support the use of parental iron in most indication. All of these slides that I have are also going to be available to you if you want to download any of these in PDF forms. So this just looks at absolute iron deficiency, where certainly you can try oral iron as your standard of care, looking for a hemoglobin increase or tolerability, or IV iron right away, or if you have the suboptimal response or intolerance. For functional iron deficiency, consider IV iron supplementation with your ESA. For possible functional iron deficiency, where you have a ferritin 500 to 800, either no iron supplementation or one can consider IV iron supplementation. And certainly if you have a ferritin over 800, TSAT over 50%, unlikely that you have any type of iron functional or not deficiency, so nothing is recommended at that time. For ASCO and ASH clinical practice guidelines, again, these have also been somewhat updated recently with the expert panel reviewing 15 meta-analysis and looking at all the data published from 2010 to 2018, suggesting that adding iron supplementation to ESA, they agreed, improves hematopoietic response and reduces the likelihood of red cell transfusions. However, at this point, what they said was iron replacement can be used to improve your hemoglobin response and reduce red cell transfusion for patients receiving ESA with or without iron deficiency. Biosimilar products, which I think we got to look at a lot of these studies as we're using more and more of these biosimilars, may be offered to patients with CIA whose treatment is not for curative intent, remember, and where your hemoglobin is under 10. And with notable exception, our patients with myelodysplastic syndrome with ESA should not be offered to most cancer patients with non-chemotherapy other than MDS. And unfortunately, they still state that red cell transfusion remains a therapeutic option. How about ESMO? So the consensus guidelines here on the first is, sorry, I can't see down the bottom, but this has been updated. So I don't remember the date off the top of my head, but a few years later will be my other slides. So they just highlighted their prior guidelines, which was just saying what we needed to be monitoring here. Remember, we're highlighting the TSAT and the serum ferritin as the most useful. And then stating, yes, IV iron supplementation, we agree even the earlier guidelines leads to a higher hemoglobin increment and appears to reduce the number of patients requiring transfusion. There are updates out recently in the last 2 years. Who should receive iron supplementation at a level 1 category A level? Those patients with chemotherapy and hemoglobins under 11 or over 2 gram decrease from their baseline hemoglobin. A serum ferritin under 100 milligrams should receive IV iron formulation. And if an ESA is going to be employed, iron supplementation should be given before and or during the ESA treatment in the cases of functional iron deficiency. Should patients receive IV iron without ESAs? And at this point, their guideline is IV iron monotherapy may be considered for patients with functional iron deficiency, and of course with absolute iron deficiency. And then they also looked at the appropriate dosage of iron, IV iron for CRA and CIA, and confirmed probably 1,000 milligrams as a single dose or multiple doses per label. This can be downloaded if you'd like to follow this. It kind of breaks down on your left by hemoglobin 10 to 11, 8 to 10, and under 7 to 8 is where they actually suggest that a red cell transfusion might be needed at that level. And of course, they highlight ruling out, as we've mentioned, other causes of nutritional deficiencies such as vitamin B12 or folate, and also using your serum ferritin and TSAT to guide you. I'm going to switch off of the clinical trials now and talk just for a few slides about the health economic impact of IV iron usage in cancer. So we don't have a lot of data here generated from the United States to look at the cost benefit of IV iron over not using it with ESAs, over using red cell transfusion. But this is some studies that were done in Europe, which I think can highlight And if you look at the EU to US dollar, it's almost 1-to-1. So you'll be able to get a little idea for the EU, how much money we could be saving. So this is a study that was done in Switzerland in 2013, and they looked at utilizing 3 data sources. They have a PolyQuest prescriber analysis, which is a telephone and oral survey that was done in thousands of patients. They did a chart review, which is an anemia patient record study that added about high 400s of patients. And they looked at the IMS, the Intercontinental Health Sales figures for iron sucrose and ferric carboxymaltase. Why they were doing this was their standard iron preparation was iron sucrose. Once they had approval for FCM, they wanted to look back a few years to see the data that looked at the budgetary impact on these two and whether there was any benefit to one over the other. So that's the reason that they were looking at this. The patient populations they looked at, I'll just highlight down the bottom, there were very few patients who had cancer. Most of them were pregnancy, inflammatory bowel, chronic kidney disease, CHF, and heavy uterine bleeding, and surgeries. And this is listed the percentage of patients. The number of patients is about 97,000. So that was the percentage of patients. This is their chart looking at the cost savings that were observed with FCM over iron sucrase per treatment cycle for all dosage. And the one thing to look at, I can't really use my pointer here, is in 1, 2, 3, 4. If you look at the first, the fourth bullet point down in the first and subsequent ones, it is the personnel costs, or third rather, personnel costs. So here what they're looking at is the number of doses, the number of hours in their infusion suite, and that really was the driver here for the cost saving, was the fact that we had total dose iron that could be given, shorter infusion times that could be given. So the actual cost per milligram was pretty similar, but the cost saving here was 42%. And when they looked at that for 1 year, that was a cost saving of $20 to $32 million in the health system. Another meta-analysis they did also in the Swiss healthcare system was looking at backwards in 8 randomized clinical trials. Again, conservative estimates here. They really could not account for the fact, how about if giving IV iron also reduced the number or the amount of ESAs you were giving? That would be a cost saving. How about if you gave less transfusions? That could be a cost savings. So this was a very conservative, again, look at their IV iron in addition to their ESAs. And again, 24% of IV iron led to a 24% absolute increase in the proportion of ESA responders. They want to look also in the future, as I mentioned, at the ESA reduction or the less ESAs that has to be done here. And again, pretty significant cost-effective ratios, as you can see down the bottom for FCM. So for my part, the top line summary here is CRA and CIA are inherently inflammatory in nature. The anemia of inflammation, anemia of chronic disease really defines cancer, and chemotherapy itself, obviously by its myelosuppressive nature and other causes, especially on renal function and lowering of erythropoietic, endogenous erythropoietic levels, is governed largely by Hep-Cyton, which gives to a functional iron deficiency. The reviews that I've covered in the meta-analysis, as well as the individual randomized clinical trials, have shown IV iron to be particularly useful in CRA and CIA by virtue of improving hematopoietic response rates and also the time to get to your response, reducing red cell transfusion burden, and the benefits were seen both in combination with ESAs and as monotherapy. Most of these studies outperformed oral iron and certainly no iron as key efficacy endpoints, and there was no significant risk for adverse events, which we've heard. IV iron is now endorsed by expert consensus guidelines in NCCN, Asco, ASH, and ESMO, and a little bit on the IV iron and ESA associated with the cost savings versus ESA monotherapy. Thank you very much.
Thank you. Our last speaker will be Dr. John Glaspie from UCLA, who's going to give us a look in the future of potential agents to use that we can use to treat CRA.
Thank you, George. I'm going to not look at the future until we look at the past. I'm going to try and do the past whirlwind tour. Many of you lived through this. But mistakes were made in our approaches to anemia in cancer patients and cancer chemotherapy patients that the price for which we're still paying to this day. This is the current understanding, at least my current understanding of the biology of cancer-related anemia. Our understanding when we started treating cancer anemias in the late 80s, early 90s with something other than transfusions was we knew that Carol Miller and Jerry Spivak had published a paper that said that cancer patients have a relative endogenous erythropoietin deficiency. That is, in those patients, as they become more anemic, their endogenous EPO levels rise, but not nearly as fast as iron deficiency patients say. And it was based on that that we said, well, this is a EPO deficiency disease. EPO has been a tremendous success in nephrology. Let's just do that. And that worked, and it led to some success. In my opinion, it showed that we could make cancer patients feel better and that we could reduce transfusion burden. But we didn't pay attention to the details. One of the details was that the doses of erythropoietin that we were having to give in cancer patients was 3 times higher than it was in dialysis patients. If this was a pure EPO deficiency problem, that wouldn't be the case. And instead of a response rate of 90 or 95%, we had a response rate of 50%. And we didn't have the stuff in yellow or gold on the slide here. We didn't have any of that in those days. But we had a clue that there was something going on that made these cancer patients different. And what we've seen happen is gradually we're learning the biology better, and we're learning what to do. And we have a way forward for the future, and that will be the future part of the talk. The problem, one of the problems we ran into with ESAs in cancer patients was that there were a few trials published that said survival was lower in the patients who got the erythropoietic agent than the control patients. That wasn't consistent across trials. None of the trials were designed for survival as an endpoint. There was no stratification at baseline to balance the survival perspectives in the 2 arms. But it raised a legitimate concern in many people's minds about what's going on here with this. And that's why we have the restrictions we have on erythropoietic therapies, that plus the cost of the treatment, which had become very burdensome. Now, as we think about safety, it's interesting that the first trial that got us into this was a trial by Tim Littlewood from Great Britain, who said, now that we know we can lower transfusion risk and quality of life goes up, what if we push hemoglobins all the way to normal or right above normal? And he did that in a small trial and showed that it improved quality of life, which was the main goal of the trial. But he also published a supplement to his paper that said it improved survival. And everybody jumped on the bandwagon. We all drank the Kool-Aid and said, well, that makes sense because hypoxia is caused by anemia, and tumor hypoxia makes the tumors behave aggressively. So now we should think about using these drugs in an optimal way to make cancer outcomes better. And that's where the train came off the tracks. There were a few trials of high hemoglobin levels, superoxygenation trials, we called them at the time, that were problematic trials and had a survival difference. And so we started wondering if there's a negative effect on survival, and we still don't have this all the way worked out. If there's a negative impact on survival, is it coming from receptors on marrow because we're driving people too high and that makes them hypoxic, or we're leaving them too low and that makes them hypoxic, and we haven't found the Goldilocks hemoglobin level for a cancer patient? There's lots of biology behind this we don't have time to go into, but in measuring tumor oxygenation with Eppendorf needles, you'll see hypoxia at anemic levels, and then it gets better as you treat the anemia. And then when you get towards normal, you start to get hypoxic again. So it all seemed to hang together with marrow EPO receptors being something, the only thing we need to focus on. And then the rest was a big fight that took 10 years. And one of the fights was surrounding tumor EPO receptors. Those were initially demonstrated using sera that cross-reacted with heat shock proteins. And so all that was called into question, and not much has happened with this tumor EPO receptor in the intervening time. Vascular EPO receptors are a good place to start an argument. Many biologists don't believe they exist. Some of us wonder why hypertension happens when you give patients an ESA even before hemoglobin has risen, if there's no effect on vasculature. And the most important piece of evidence is that there's an increase in thrombosis risk when patients receive an ESA. That's pretty clear. And whether that was contributing in some interactive way with cancer or simply causing a problem with survival due to the downsides of having thrombosis has remained unclear, and we still don't have proof that there's a vascular EPO receptor. If you're not confused enough yet, I'll try to take it one more level, and then we'll deconvolute. The first evidence that we had made a mistake wasn't that we figured out what Hep-Cyton was doing. It was Michael's paper showing that one of the reasons the ESAs were not producing the same response you see in dialysis patients was because the patients needed iron supplementation in order to get their maximal response. Everybody has their favorite meta-analysis. Here's mine. It's now pretty clear that EPO works better in cancer anemias if patients also receive parenteral iron. Why that is the rest of the story and going to be the way forward. So we start with Hep-Cyton. Everyone else has talked about the effects of Hep-Cyton, what Hep-Cyton affects. And because there's two sets of ferroportins we're interested in, one is the GI tract lining, which is relevant to functional iron deficiency because it's relevant to absolute iron deficiency because it affects absolute iron absorption. And the other, ion storage cells, are relevant to functional iron deficiency. You've had this drummed into you tonight enough. I want to talk about what affects Hep-Cyton, not what effects it has. So Hep-Cyton, the gene that encodes Hep-Cyton is called HAMP, and HAMP expression is regulated by bone morphogenic protein acting through the SMAD transcription factors on top of a baseline synthesis of Hep-Cyton regulated by STAT3, hepatic nuclear factor, and CEBP. Those are the positive factors that promote expression of Hep-Cyton. And when you look, hypoxia causes two things. One, it causes production of EPO, and we're going to get to why that is on the next slide. And then that EPO, among other things, should decrease Hep-Cyton. It acts through the EPO receptor to block to decrease the transcription of HAMP. There are EPO-independent pathways that work through macrophages and a factor called hypoxia-inducible factor that affect Hep-Cyton independent of EPO. And it turns out it's too bad, but if the EPO dependent part of this hepcidin down regulation pathway was more important than the non-EPO receptor part of it, we might have had a lot more success way back in the early 90s. We might have not driven costs sky high. We might not have used really high doses of EPO, and we might be in a much different place today in terms of how we manage cancer anemia. Next up is a guy named George Semenza, who received the Nobel Prize for working out the biology of the hypoxia response. In a normoxic cell, there are transcription factors, 3 of them, all hypoxia-inducible factor 1, 2, or 3, but all called hypoxia-inducible factor, that in an oxygenated environment are hydroxylated very quickly. And once they're hydroxylated, they are ubiquinated and eliminated very quickly by von Hippel-Lindau mechanisms. So we don't let, as a baseline, this system run away. When we're normoxic, we don't keep HIF around. I'll show you why in a second. When we're hypoxic, we stabilize HIF. And stabilized HIF is a potent transcription factor that regulates what's called the hypoxia response element, which is a huge cassette of genes that includes erythropoietin, the EPO receptor, glucose transporters that help make PET scans work for us, Hep-Cyton, it decreases Hep-Cyton expression, DMT1, you heard about that in terms of its effect on iron transport in red cells, transferrin, etc. It's a key regulator of everything we've been interested in tonight. Now, you can make a small molecule that will block these hydroxylase, these HIF prolyl hydroxylase enzymes, and create a pseudo hypoxic environment that makes the cell make those things that we talked about. This is a perfect target for small molecules. It was initially discovered because a company working on fibrosis and was blocking prolyl hydroxylases for that reason with some of their drugs, noticed that their mice were getting problems with really advanced polycythemia. And it turns out that what they were doing was stabilizing HIF. And so that's one of the agents we're going to close by talking about. Now, this is a real good paper from Nature Reviews regarding these agents, and they're going to be very complicated. There are several of them now. Their main goal is to raise HIF-2 alpha to stabilize it so that the erythropoietin production will go up and hemoglobin will go up. That's pretty much what the goal is in renal failure, where these things have been close to fully developed now. But there are other areas that we've talked about, especially iron homeostasis. We just went over that and its effects on Hep-Cyton, energy metabolism, the glucose transporters, angiogenesis. VEGF is under regulation of the HIF response element. And you can imagine some other side effects, some other potential effects that there will be off-target toxicities as well. There often are with small molecules. This is going to be complicated, and one drug is not going to be the same as another. They're going to have different proportions of what they do, different PKs, different dosing regimens. There's a lot of work to be done here. These are the 5 that are currently in clinical development. I'm going to show you some data with Roxidustat and some very recently published data with Daprodustat. Their applications are obvious: renal failure, myelodysplastic syndromes, and anemia, chronic illness, including cancers, et cetera. And there are hopes that these things will find their way into other areas as well. So if you didn't see it, this is the one of the Roxidustat papers that was in the New England Journal a year or two ago. These were dialysis dependent patients, so they were already on an ESA, and they were randomized to be switched or not be switched, and then hemoglobins were followed. These were patients were getting once or thrice weekly, so 3 times a week, Roxidustat tablets. And one of the main goals was to see if it eliminated the effect of inflammation on the efficacy of erythropoietic agents. You'll see in the second graph over that that appeared to be the case. There was not a decrease in efficacy or a need for higher doses in patients who had high CRPs, unlike EPO. The changes in Hep-Cyton levels are shown in the 2 boxes on the lower left, and then the baseline low CRPs versus baseline high CRP dosing. So these drugs do not have a different dose when there's inflammation. That was our big problem back in 1991. We were having to dose cancer patients because they had inflammation much higher than dialysis patients who had a more pure EPO deficiency state. Now, the problem that is currently being worked out is their effects on clotting. Now, there's two groups of patients shown here. This is pulled from the FDA review of Roxidustat in dialysis patients, and these are vascular access thromboses. There is placebo data in the non-dialysis dependent. So this is placebo versus Roxidustat, and you'll notice that there's more vascular access thrombosis. It's instead of 0.4%, it's 2.4%. If we look at the Roxidustat versus epoetin data, where it's dialysis dependent and they're on a switch study and they're both arms are on active treatment, the differences are much smaller. They're on the order of 13% versus 10.5%. And digging deeper, it looks like the Roxidustat rapid responders were the ones that had the biggest risk of clotting. So going back to the drawing board with Roxidustat in its further development, attention is going to need to be paid for the rapidity of response and make sure that that's optimized. Okay, same thing for DVT. It is DVT compared to placebo is 1.5 versus 0.5, but for dialysis where there's an active comparator, it's 2.1 versus 1.9. Daprodustat. Now this is a trial in patients who weren't on ESAs. They were non-dialysis dependent CKD patients, and they were randomized to receive darbepoetin alpha or daprodustat, and you see the hemoglobin curves there. In terms of their toxicities, remember this is active control. MACE was a grouped variable for mortality, myocardial infarction, and stroke, but it doesn't matter whether you look at MACE alone or MACE with all the other endpoints that are concerning for thromboembolic events. There didn't appear to be any. Here, this is a different drug, not dosed thrice weekly, but dosed daily. So there's tons of work to do in this field. In terms of MDS, we worry about iron overload in MDS. We even worry about it making the MDS progress faster by causing reactive oxygen species to damage DNA further in the heavily iron overloaded marrow. At last year and the year before that's ASH, David Henry presented the phase 2 Roxidustat trial, and I'll just skip ahead. The response rate was 23% in patients with ring sideroblasts and 55% in patients without ring sideroblasts, which is pretty good. it didn't seem to be affected much by baseline EPO concentration. So the PHD inhibitors, I think, are what we're going to be doing in this field from here forward. They're going to change how we think about iron because they do more to free up iron and make functional iron deficiency less of a problem if they have a clear-cut and consistent effect on Hep-Cyton. All of the safety issues haven't been overcome because we've got this thrombosis issue to work out, but it's very early, and at least we know we have an issue, and we know we need to work it out early in a drug's development. Okay, and so I'll sort of close there and not do the top line review so we stay on time. Okay.
Thank you, John. So what we're going to do is some of the faculty have put together cases, and I'm going to ask the faculty that developed the case to present it and discuss it. I think the first case is from Tom.
21-year-old. Oh, I get to go. Ooh. Okay. The person's podium. So AG is a 21-year-old college student, and she's noticing increasing fatigue. Being in Portland, she's noticed her running pace is notably slower than normal, and the suspected etiology perhaps of her iron losses or menorrhagia and distance running, which actually is a strong association with iron loss. Next slide. Oh, I guess I can do it. We know her hematocrit is not all that abnormal, but her MCV is also normal. But her ferritin's low at 15 and her SATA is low at 15. I sort of put this on here and brought up this case to bring up some salient points that, again, as Dr. Arbach elegantly went over, that we're really discovering that even with not being anemic, having low iron stores is detrimental. There's 2 randomized trials showing that actually ferritins under 50 are associated with fatigue that can be improved with iron replacement. There's a lot of evidence in athletes that non-anemic iron deficiency could be detrimental, perhaps due to loss of muscle ferritin, and that indeed she is iron deficient. So she has absolute iron deficiency. She is symptomatic. And at one point, again, to go on what Mike said, is that many labs really have misleading ranges of normal for ferritin. Actually, one of our residents is going to have a presentation at a local ACP meeting, actually looked up ranges of normals of ferritins for a variety of labs on the West Coast. And, you know, some had thought a ferritin was 9 was acceptable for an 80-year-old woman. And so they really got to take lab normals with a grain of salt, and just anything under 30 to 50 is probably more realistic. She was somebody who we elected to use oral iron on, whatever dosing we like. I tend to be more of a once a day fan because I can't remember doing something every other day. And so we did that. We only did it once a day, knowing that BID, TID, get blockage of absorption and increase in symptoms. And our goal is really to get her ferritin over 50. From the data we know, both with athletics and fatigue, of improvements seen over that. So the points I want to really make about this case are that, again, she is absolutely iron deficient. A lot of times my patients will say, oh, my iron's been normal, because they'll go to the doctor, their CBC's normal, nobody's even checked a ferritin. That really we can't go on lab ranges of normals of ferritins, that we really have to think of goals of 30 to 50 for age and situation being more appropriate. She was responded to oral iron. I actually have quite a few athletes who are not, for a variety of reasons. Interestingly, intense exercise raises Hep-Cyton, so there may be playing a role with that. And again, especially in athletes, there can be a lot of reasons for iron loss. So Hep-Cyton blocks iron absorption. There's great studies done that show that running actually leads to increased iron losses. And so when, again, have a pretty broad base of view when evaluating somebody with iron deficiency. So we'll go to case 2.
With lower esophageal HER2 positive adenocarcinoma. with metastatic disease in the liver. He received chemotherapy plus trastuzumab, and a near complete response occurred after 3 cycles that it would have lasted. At presentation, his lab values were hemoglobin of 10.9, MCV of 94, serum ferritin of 642, and a percent transferrin saturation of 7. I don't mean to be sarcastic or facetious, but you could add a 0 to the 642, and the same conclusion could be made. And had liver metastasis, the serum ferritin needs to be ignored. Percent saturation of transferrin informs on the need for iron. 1,000 milligrams of low molecular iron dextran was prescribed. 40 seconds after the test dose, there was the sudden onset of flushing in the face, followed by pressure in the chest or back. You'll see the following slide in a second. Can we see it, please? Or wait, I have it. I'm sorry. Okay. This is not his normal color, by the way. In case any of you want to know why his eyes are not blacked out, he actually asked me not to do that. He's bright red. You can see there's anxiety in the face. There's pressure in the chest and back. Several minutes later, well, I was expecting a different slide, but we're okay. Methylprednisolone and famotidine were administered. The infusion was stopped within 7 minutes. All symptoms and the rubor had abated. I think you'll see that in a second. Another 15 minutes of observation were followed by the infusion of the balance of the low molecular weight iron dextran. That would be a most unusual event throughout the Western world because of the folklore that surrounds IV iron danger. The following slide provides an evidence-based algorithm for the management of hypersensitivity reactions to iron. It looks like we're not going to get to see my healed patient who was smiling and with a normal color. This was published by Rampton et al. In Hematologica in 2015. It's a marvelous approach to the patient with a minor infusion reaction. On the right is what happens when you have anaphylaxis, but that's not unique to iron. It's with any intravenous formulation. But the important thing to notice on this is in column 1 and column 2, and for column 3, you have a patient in shock, so pressors are administered, but nowhere in this algorithm do you see the use of antihistamines. Oh, here he is. Good. Here's this is not 4 weeks later. This is 4 minutes later. But he did return to the clinic with a hemoglobin of 13.8, a serum ferritin of 840, liver mets were still there, and a percent saturation of transferrin of 28. The moral here is that you cannot use the serum ferritin in a patient with metastatic disease. The percent saturation of transferrin works. There are other parameters that do. The reticulocyte hemoglobin would. Soluble transferrin receptor would as well, except it's not readily available. And there is standardization issues. But I think that the 2 points I wanted to be made was the management of the minor infusion reaction and the use of the percent saturation and not the ferritin.
So this is a 72-year-old female who is one of Jehovah's Witnesses with the inability to transfuse based on religious conviction, who had an advanced serous ovarian carcinoma and was planned for neoadjuvant chemotherapy, as it was felt that she was primarily inoperable, but the whole goal would be to get her to an optimal debulking surgery. So she was going to get paclitaxel, carboplatin, bevacizumab, carboplatin being the agent that would cause the most, because it's a platinum agent, anemia, and at baseline, her hemoglobin is 10.4, ferritin 100, TSAT 70%. So kind of highlighting here our functional iron deficiency of anemia of inflammation / malignancy. Serum creatinine a little elevated at 1.2, but you can see our endogenous erythropoietin level for degree of anemia is blunted. So highly suggesting to us that she could benefit from both parental iron and erythropoietin. And I'm planning for trying to get in a curative fashion for this patient dose intensity in my agents to get her to surgery, and small chance, but a chance for cure. So she was given FCM 750 milligrams with cycle number 1, cycle number 2, every 3 weeks dosing. The hemoglobin already is up to a little bit at 10.9. By cycle number 4, even though the hemoglobin is 9.8, she gets a second dose and then erythropoietin with her permission, knowing that this is a potentially curative and the ESA black box warnings, but the inability to be able to transfuse her kind of outweighed any small potential theoretical risk with the ESAs. She agreed to move forward with that. And we finished cycle 6 with a hemoglobin higher than what I started, allowing her to proceed directly to surgery without the need for transfusion. And just as some follow-up for that, she did have the ability to be optimally debulked. So that was really just highlighting how we have to check our labs at the initiation when we first have anemia, and we have to make our plan for parental iron ESAs. There may be a role for intravenous iron alone to get you a little increase in the hemoglobin, but in this case, I really felt it was warranted as my hemoglobin was declining to add on an ESA in her case, which allowed me to continue on with full cycles, no dose reduction, and move forward with a curative surgery.
So a question for Dr. Glaspie in terms of the future directions. Can Hep-Cyton be measured? Can anti-Hep-Cyton antibodies be given? What is there a future for Hep? I would just add, are Hep-Cyton assays going to be clinically useful?
Yeah, well, I don't know if Hep-Cyton assays are going to be necessary or useful, but it can be measured. So I've shown you the data, but the question will be, are we going to need to measure them once we've used them in clinical trials to prove what we need to prove and to get where we need to get? And that I don't know. And the other question was antibodies. There are 11 biotech companies I'm aware of who have been started up around this Hep-Cyton, anti-Hep-Cyton issue. Antibodies aren't the only strategy you see out there. I showed you one, the HPD inhibitors lower Hep-Cyton levels, so they're in that marketplace as well.
Okay, and this is for any panel member that wishes to comment on a recent publication. What do you anticipate to be the clinical impact of the recently published ironclad study evaluating ferric carboxy maltose as monotherapy in CIA? Anybody?
Be a good one for you.
Sorry?
I think that's a good one for you.
Well, I think it confirms the utility of monotherapy for CIA, and I think, if my memory serves me correctly, that it also had one of the longer term follow-up in terms of long-term safety. So I think it definitely was a useful study. Any other thoughts on it? Okay, and this is directed again to all or any panel member. How exactly does IV iron overcome the effects of Hep-Cyton? Why and how is it better than oral iron when Hep-Cyton levels are high? I think we'll let Dr. DeLaury.
Sure.
That one.
I think there's several things. One, it bypasses what I call the mucosal block because of Hep-Cyton. One cannot absorb iron. So when you give IV iron, you skip that absorption issue. And then secondly, when high doses are delivered, you get iron into the circulation, you get iron delivered better to the developing erythroids. So there's by multiple pathways, the IV iron can bypass the Hep-Cyton block.
Sure. I mean, IV iron can rapidly bind to transferrin and therefore is more bioavailable for the erythron. Again, a question for any or all panel members. In anemic cancer patients,
Dr. Ford showed us data as well that suggested that another advantage of the IV iron in that situation is that it can unblock the macrophages by restarting ferroportin production.
Yes, I should
Right?
do that.
correct.
If that's true, it might have been Michael showed the data. So that would be another answer to that question.
Thank you. I think Michael alluded to this. I'll let him expand on it. In anemic cancer patients, soluble transferrin receptor, is it better than TSAT and ferritin? I think you mentioned somewhat.
I think it certainly is good. The problem is getting it. It's not routinely available. And there's a problem with standardization from one lab to another. So it's just not a routinely available test. If it were, it certainly would be.
Another question again for any panel member. Are there any new developments in oral iron formulations which might improve the utility of oral iron that anyone is aware of? And
Well, I think that there was a recent paper in Lancet Hematology, in Journal of Maternal Fetal Medicine, lactoferrin. It looks as if it's better tolerated. Whether or not it's equally effective, we don't know, but it's still, none of it gets past the ability to overcome the Hep-Cyton block, and certainly in situations like pregnancy, inflammatory bowel disease, and gastric bypass, it has no advantage.
okay. Those are all the questions that have been submitted either electronically or on written format. Any comments? Questions for the panel? I guess we are adjourned. Thank you.